Welcome to Moving Conversations, a podcast for movement professionals by movement professionals. If you coach, train, or teach movement, Pilates, or fitness, then this podcast is for you. With more than 60 years of experience in fitness and Pilates, your hosts, Brian Ritchie and Nora St. John, explore the science of human movement, diving deep into the facts, myths, and common misconceptions, hoping to spark thought and conversation about how we view fitness and movement. Now, let's jump into Moving Conversations. And welcome back to Moving Conversations. This is Brian Ritchie. Joining me as always is, well, if you're watching on video, you're not going to see Nora today, but you're going to hear her voice. So Nora St. John is joining me. We've had a little bit of technical difficulties, but you will hear her voice. She will be the floating head. She'll just be this voice from the other side talking to us. And for those on audio, it's going to be the same thing as always. So how you doing, Nora?
I'm doing pretty well. We're in the middle of an atmospheric river here, so it's gray and wet. But this is California, so that it's always a welcome thing.
Well, you were saying last time that it was like a cyclone bomb or something was coming through.
Yeah, there's it's just a big whole bunch of, it should be wet for another 4 or 5 days, which is unusual here. So, but it's nice. It's been kind of a mild rain, just keeps raining, which is good. The river hasn't gone too high. Our everything's still draining. So life is good. How about you?
Doing all right. I mean, yeah. I had 2 clients come in today telling me that we've had flurries. So
wow.
I can't see, anything, but that's doesn't mean it doesn't exist out there. So before I leave the office today, I'm definitely going to check, because here in Washington, D.C., I'm sure it's the same in California. As soon as there's one flake on the ground, everybody loses their mind and forgets how to drive.
Yes.
So we're not Minnesota. People don't, automatically know how to handle weather here. So yeah, rain, will flummox some drivers. So a couple of, flakes and oh my gosh, they're going to freak out. So it may be a little longer drive home than what I expect, but that's all right. It's winter and we have had 0 snow practically for the last 3 or 4 years. So, it's kind of, we're due. Everybody keeps saying that every year that, we're due for a blizzard or 2. So it's like, well, we'll see what happens.
Well, you're also, DC is such a funny area. In terms of people being transient. So you got a whole lot of people there who may have never been in the snow because they're from the South or they're from the California or whatever. So you got people who come and go and really don't know how to deal with the weather.
Not only that, quick funny story. I was friends with a chiropractor and we were going to lunch, and afterwards I followed him out of the parking lot. And it was snowing, and it was there was snow accumulating on the sidewalks and things, but not on the road. The roads were fine. He was from Trinidad.
Oh, wow.
He was driving at about 5 miles an hour in a 45, and I'm behind him. I'm losing my mind. I'm losing my mind. People behind me are honking, and he's driving so slow. And I said, you know what? Where he grew up, like me, I grew up in Hawaii. I didn't grow up with snow, but I've spent enough time in the snow that I've gotten used to it. It freaked him out. And the next time I saw him, I teased him about it. He said, oh yeah, I don't do snow. I don't do snow. Nothing, no snow. So, so it's like, we have a lot of people, not only from other parts of this country, but from countries who have never experienced snow a day in their life. So yeah, it could be a huge change here.
Well, speaking of snow, this is our part 2 of our getting back into action. So Brian and I both have a lot of expertise and a lot of experience with a lot of clients with back pain. Brian has wrote his amazing book, Back Exercise, Stabilize, Mobilize, and Reduce Pain. And we want to talk today about another kind of low back pain. We talked last time about non-specific low back pain, some general thoughts about how we assess those as movement professionals. And today we want to talk about issues that can happen with the bones. So this is not so much the musculoskeletal system, although it will be affected by the joints and the bones. But what happens to the bones and the spine and how that influences the rest of the body?
Yeah. And before we get to that, though, do us a favor, hit the like and subscribe button if you would, please. It helps us out greatly. And that way it'll be in your feed every Tuesday morning when you wake up. It should be there ready and waiting for you to listen to us. Also check us out on Instagram at Moving Combos, Moving Conversations, as well on Facebook, that's the word. On Facebook, Moving Conversations. You can also get to us at movingcombos@gmail.com. Do us a favor. Let us know in the comments what you'd like to hear, what you'd like to see, or for something like this, especially for low back pain, what do you do with your clients? What are your suggestions? What things have you, seen that have worked? Because Nora and I are always looking to learn. So we'll learn from you as much as you can learn from us. So please, in the comments on Instagram especially, or hit us up in an email, or on YouTube under Brian Ritchie. Those are the best ways to get in touch with us, and we will respond. So yeah, let's jump into the low back.
All right. So thinking about key things we're going to look at here is things like osteoarthritis. So how that influences the spine. And a lot of times, again, that is what happens often with time. Looking at things like stenosis or narrowing of either the central canal in the middle of the vertebra or the two channels that the nerves come out of on the sides. Looking at spondylolysis, which is a fracture of typically the kind of the arch, if you want, the vertebral arch away from the vertebral body, or spondylolisthesis, which is where one vertebral body moves out of alignment with those around it, typically forward, sometimes back. Yep. So that's a lot of things to talk about. There's some similarities in terms of how you work with them, but let's just kind of go through what they are, what that means, what the ramifications are for those different issues.
Yeah. When you mentioned something for, our listeners, I just want to clarify, when we talk about osteoarthritis in the spine, you don't often hear the term arthritis as much as you're going to see and hear degenerative joint disease or degenerative disc disease. Those are often used instead of arthritis because it's very specific to the spine. And degenerative joint disease, often they're going to be talking about, what's going on within the vertebral arch or within the intervertebral space or the facet joints. And you'll also sometimes hear facet joint syndrome. If the facet joints themselves have been worn away and have some bony, additions to them, some bone spurs. And degenerative disc disease, DDD, is often when that disc is collapsed. And I've got my little model here, since you can still see me on video, where the disc is actually collapsed and you've reduced the disc height. And there's usually damage to the vertebral end plate, which is what feeds nutrients to the disc. So the disc itself can become dried up, brittle, and you can begin to lose height that way as well.
So this is all everything so far, just talking about arthritis or DJD, DDD, is looking at how time typically and where and potentially bone growth, so osteophytes, that kind of thing, can decrease the space that the nerves run through. So if the disc shrinks, and this happens with time anyway, most of us get a little shorter as we age because that disc loses some height. And that can be just a simple process of drying up a bit, or it could be a more pathological process. So that disc shrinks and that decreases, Brian's got a good image up on the screen here, and that decreases that space that the nerves come out from the central spinal cord. And that can then put pressure on the nerves, causing versions of sciatica. Now, that could also happen simply because maybe the disc stays the same height, but that facet joint, the joint between the two vertebrae, or even the vertebral body, starts to grow osteophytes. Osteophytes are like little stalagmites and stalactites of bone that start to increase the size of the bone and decrease the space that the nerves can come out of, either on the sides, either laterally or centrally.
And that is stenosis. And in the past, we've talked about stenosis, so we went into a deep dive into that, and we'll discuss it again today. When you have stenosis, it usually is just a bony growth that's either going to happen in the central canal, which is central stenosis, or it's going to happen through that intervertebral space. And again, that's just that bony growth and begins to impede on or impinge that nerve. And that can cause, a great deal of discomfort, pain, numbness, tingling, radiating pain. Go back to our sciatic episode 2 episodes ago, and it'll, be covered a little bit more in detail there.
Then looking at, so that's kind of our stenosis, and oftentimes it's osteoarthritis related or it's disc deterioration related. Then we also have something called spondylolysis or a pars interarticularis fracture. A
Hmm.
pars fracture is sometimes called, and that's where that vertebral arch, if you think about a vertebra as being like that little round body of the vertebra, and then there's a little ring of bone that sits on top of that. And that's where you have a central hole, which is your spinal cord, essentially, your central foramen or central canal. And then you have the transverse processes sticking out the sides, spinous process sticking out the back. A fracture of that arch typically is going to happen at that arch, oftentimes at the pedicle, and either one or the other will create a little bit of instability in that area. And sometimes that's a different kind of pain. Sometimes it may not be a nerve pain. It may just be like soreness, localized pain, discomfort, that kind of thing. And it's an instability in the spine, right? And again, you can have a fracture on just one side or you can have a fracture on both sides. And this is where we think about, if you've got a fracture on both sides of that arch is no longer firmly connected to the vertebral body, you want to be really careful with that. Because if you do something, let's say extension, that pushes that vertebral body farther away from that vertebral arch, you've got potential trouble. So when you've got a spondylolysis or a fracture of that vertebra, that vertebral arch, typically, you want to be very careful with what movements you do that can destabilize that situation.
Hmm.
And so that's where we really focus on stabilizing, limiting certain kinds of motion. And all of this should definitely be done with the feedback from their medical professional, right? Their
Yes.
physical therapist, their MD, like what you need to know from that person, what moves are to be avoided for this particular client based on x-rays and MRIs and CAT scans, the things where they can really see what's happening in there, because you're not going to be able to tell that from the outside. So make
No.
sure you get a really good report from their medical professional. And if you're not getting one, call them up and say, hey, I'm working with this client. I got to
Yes.
know what I shouldn't do, because that's not going to be obvious to you as a medical professional. I mean, as a movement professional, and
Yeah.
you require their expertise to figure that out.
Yeah. These are usually the clients. And just in general, when people have bony issues, these are the clients who usually, but not always, usually feel better in a flexed posture. Just
Yes.
because you're going to open that area up and give a little bit more space for the nerve in case there is some bone growth there, it'll basically open that area up and give just a little bit more room. And you often relieve their symptoms. Not always, but often will relieve their symptoms. But 100% talk to the medical professional and they will tell you. I remember I had a client who was working with one of my staff, and I've told this story before, where we heard from the doctor. And the doctor said no extension, absolutely no extension. They had something called spondylolisthesis. We'll go over that in a second. And no extension, keep them in flexion. Well, I had a staff member who thought she knew better. She no longer works for me and was doing back extension work, and it made the situation so much worse. So again, we really want to make sure we listen to the medical professionals because they've seen the imaging. They've worked with the person probably longer than we have at that point and do understand what's going on. And they're going to be able to guide you into what to do with this client and what position to put them in. And once you've got them in that position and they're feeling okay and they have reduced, numbness, tingling, radiating pain, any of the symptoms, and that's really reduced, and you keep them in that posture, you can do a ton of exercises with them in those postures. All that's,
Absolutely.
yeah.
Yeah. It's just modifying their starting position essentially, and then training them to maintain that starting position anytime they're doing something stressful.
Yep.
Right. Or even just, sitting, standing, walking, ordinary life. So last version of these things, last issue I want to talk about here is, or at least maybe one of the last issues, is spondylolisthesis.
Yep.
Spondy means spine. So in this case, what happens is that the vertebral body of one vertebra will typically slide either forward or backward on the vertebra below it. If it slides forward, it's called an anterolisthesis. And it basically means the spine will be out of alignment, that those vertebral bodies will no longer be stacked on top of each other. If it's a retrolisthesis, it will move backwards. And again, those bodies won't be stacked up on each other. Most common is an anterolisthesis. I just had one of my instructors who has working with a client, and that client came in with a diagnosis of a retrolisthesis in their cervical spine.
Mm-hmm.
Which is a more common place for it, the lumbar. I've seen it a couple times, the lumbar. And so what were you thinking about that? Again, looking at it from a movement perspective, and I'm thinking about an anterolisthesis, that vertebra sliding forward. If I'm putting somebody into a extended position, into a little supported swan, where is the force going on those vertebrae? It is going forward. So if they're already a bit forward, I may not want to push them any more forward by doing particularly like loaded extension. One thing that I want to bring up here is a lot of these conditions are more common in people who are older.
Yes.
Right. But I want to bring up two cases where that's not the situation. One is spondylolysis, or that fracture of the vertebra is, I wouldn't say common. It occurs oftentimes in younger people, particularly gymnasts, ice skaters, dancers who are doing loaded extension on a young spine. So I've worked with more than one, ballet dancer and an ice skater who were like 13, 14. One of them was 17, who had a spondylolysis really from their activity. And they were required to basically just rest, get some strength, but work very neutral towards flexion in everything we did until that was healed. And then we could move on to their full program. One other thing that I want to mention in terms of spondylolisthesis is it can happen from all kinds of different things. It can actually just be how your spine was built or something that happened early in life. One of our clients at St. Francis was actually a football player for the 49ers. He was a running back. And he had a 4th degree spondylolisthesis, which basically means, which kind of means like one vertebra is not quite falling off the one below it, but close.
That's barely on. Yeah.
It was, So,
wow.
And he was a football player, which is a high impact activity, but he really didn't have a lot of low back pain. And when they look back, like they realize he probably has had this since he was a child. And in a way, his system had adapted to that. Like that was just normal for his body. His spinal cord had adapted, his muscular system had adapted, and he was able to, again, very, very high level, like very, high level activities without much discomfort there. He did have adductor strains, however. That was what we were actually seeing him for. And that took a while to heal. Yeah. But it wasn't from the spondy.
I've had a number of people with spondylolisthesis. It was very interesting for a while, for probably a 2-year period. Almost everybody who came in with low back pain had, as well as other things, but had some version of an anterior listhesis. I've had a few retrolisthesis. It's much more uncommon to have a retrolisthesis in the lumbar spine. But when it happens, believe it or not, they rarely have pain, because in a retrolisthesis, you're going to have opening of
the
that intervertebral foramen. So there's not compression there. So it really doesn't lead to the same amount of discomfort. Now, something to keep in mind, and for those of you who can see this on YouTube, here's our spine, our lumbar spine. Most common area that we're going to see a anterior listhesis is going to be between L5 and S1 because of gravity. Where that curve is, gravity is actually beginning to pull that vertebrae forward off of the sacrum. And so when we have some disc degeneration going on within the discs, that can actually cause that to begin to slump forward. We also see it in people who have had ligament damage of the spine, because we have a lot of ligaments in the posterior aspect of the spine, as well as a huge anterior ligament that actually holds this front part of the vertebrae together. And if you get too much stretching of that area, you can also begin to see that slide forward. Another reason why we see it in all our older clients, more wear and tear on the spine. So when we have that wear and tear, we're going to have those opportunities for those ligament structures to have been stretched out in ways that maybe they wouldn't if they were in their 20s. So I often see, more of the anterior listhesis in clients who are in their 50s, 60s, not usually 70s or 80s. And part of the reason, believe it or not, I've had 2 clients have this. When that occurs and they have disc degeneration, and if it's caused from disc degeneration and that is slipping forward, sometimes there'll be a natural fusing of that area that the bones will just knit together eventually. And I've had 2 clients who have had that. So it can occur so that they have not had to have surgery. They had a lot of pain in their 60s. And then suddenly the pain begins to diminish. And the doctor will do an x-ray and they say, oh, well, it looks like they've naturally fused together. On those clients, you just have to watch the posterior aspect to make sure that they don't, have nerve impingement in the back just because it's closed up. But that can occur.
One other thing to mention here is, like we said, we haven't said this yet in talking about the low back, but I want to just bring it up here. There are many, many, many things that will show up on an X-ray or an MRI or a CT scan or something else that may or may not be causing problems for that particular client at that particular time.
Yep.
Again, I've had more than one client, as you have, who've had spondylolisthesis on their X-ray, and that's not the issue. Like
Yep.
That does not seem to be the problem. There's a disc problem or there's arthritis, something else, but that doesn't seem to actually be causing them a lot of discomfort, just something that's found when they take an X-ray. So always reminder, anytime you're dealing with a low back, the diagnosis, the pathology that they're given, or the X-ray or the report from their doctor is information. It's not definitively talking about what their situation is or isn't. So just, again, a reminder of that. Got to always keep that in mind. One other thing about spondylolisthesis, it can happen from many different things. It can happen from spondylolysis, that you literally fracture the vertebra, the arch, and then the body slides forward. It can also happen from wear and tear on the facet joints, where basically the facet joints are no longer holding that spine in place. And that's, I think, this running back's issue, I think, was he just had weirdly shaped facet joints. So that vertebra wasn't held together by those facet joints. And again, to think about that L5 is really, it's at an angle. Gravity will take it forward, given half a chance. So that one is also the most common thing.
The most common reasons for spondylolisthesis normally are 2 things: trauma and genetics. Some people are just genetically predisposed to it. And it's, whether it bothers them or not, or whether it causes low back pain is another story. But it can be a genetic factor. And it was for this running back. I've seen also a lot of trauma that this will happen after a car accident, especially. Because, and with or without fracture, but it's enough trauma to sprain the ligaments in the area and cause greater instability. And eventually gravity will start pulling that forward. Or in the case of a pars fracture, then that all bets are off. And that whole area becomes incredibly unstable. And that disc will want to shift forward if given half a chance.
Yeah. So again, we've got this idea that for many of these conditions, if they are symptomatic, particularly, you want to focus on a bunch of things, but primarily you want to really think about not closing those discs, closing those joints, I should say. You want to keep those joints open. And that often means more of a flexed position, looking also always at that core support, that axial elongation, because there are a couple of ways to take pressure off those nerves. One is by just moving into flexion, passively or actively. The other one is really focusing on getting that lift and length into the lumbar vertebra. So all that core work that we do, the multifidi, the transverse, our pelvic floor, our diaphragm, getting the inner unit to really work and support those vertebra is the other key piece. And so I often think that I'm using flexion as my pain relief, right? So to give them the ability to actually work. And then I also want to really work on that core work to allow them to feel that decompression in no matter what they're doing, right? Whatever position they have to go in for their life.
What most people don't realize, I think, is when we think about core work, a lot of people will try and do things like back extensions or even side bending or flexion crunches and even in planks. And a lot of, at least in the fitness world, is involving hold it tight, and that can actually cause compression.
Yep.
By tightening all those muscles, we can actually cause compression, and that compression can actually lead to greater discomfort because it can
Yes.
actually begin to decrease that joint space in the back, those intervertebral foramen. It can begin to decrease that, causing possible nerve impingement, etc. And if you've got bony things back there, it just makes it a lot worse. So by putting them into that posterior tilt and really getting their core to engage, but to think about, like you said, axial elongation, to think about lengthening, not just shortening the muscles, it can actually be very beneficial.
So I'm thinking about a curl, right? I think just a basic abdominal curl.
Mm-hmm.
Right. And there are ways where you can do that. And I'm just thinking about this in terms of movement experience, but there's a ways when I can do a curl where I'm like pushing back into my low back, or I'm really pulling my abdominals together and I'm squishing things down. And there's a way when I can actually think about lengthening my spine to bring myself up.
Mm-hmm.
And I can get the same action out of it. I can get the same amount of work out of it. But one is really thinking about like how much force can I push down into my spine by pulling everything together? And one is like how much length can I get out of my spine as I'm coming into that flexed position?
Yeah.
So oftentimes, and the reason I say this is because the high level tools that we have that Brian and I have certainly worked with for a long time is, yes, there's a curl. I can think of a basic abdominal curl when you're not focusing on a neutral lumbar spine as being a flexion exercise, right? And that's kind of would be a go-to core work flexion exercise.
Yep.
But there are different ways to tune that, to fine tune that exercise to make it more beneficial for your client who does have a tendency towards compression. Right. So a lot of times what we're talking about is these are exercises you're familiar with, nothing new here, bridge, curl, that kind of thing. But what do we do with the spine? How do we cue it to get the most amount of support in that area for that person?
Yep. And especially, I love that you brought up the curl because that is one that gets a bad rap. And a lot of people say you shouldn't do it. And unloaded, it's really not that big a deal. And for a lot of clients, doing a curl, especially if they need to be in flexion posture, can be beneficial. But I love the fact that you're talking about doing more of an elongation as they're curling up, lengthening the spine, rather than just thinking about crunching down. Because anytime you go into gyms, some of the most popular equipment are those ab machines.
Yeah, the
Because
crunchers.
they're easy.
Yeah.
For a novice who's never done anything before, oh, I sit here and I just do this. Oh, I could do that. And it's fine for some people, but if you have a back issue, you're really just causing more and more compression every time you go down. Every time you're pulling that down, it can cause greater compression. So just be aware that you're really wanting to think about lengthening the back of the spine as you're doing your curl.
Exactly. Thinking about things like, so a lot of times for me, what I'm trying to do is I'm trying to get the core to fire. I might say reflexively. I think that's probably a way to talk about it. And I'm trying to get it to just like kick in when it needs to support the person. And so things like planks, things like opposite arm and leg reach in all fours, things like any kind of suspension training, so leaning into straps, that kind of thing. And with all of those situations, which are exercises where the core will fire, but it doesn't need to be flexed, it doesn't need to be extended. So this is just like, how do I work the body without moving the spine, basically?
Yep.
And in all those situations, it's really about, okay, how do I get that sense of length? And for these clients, maybe they are in just a slight flexion. So think about in a plank, for example, we're often trying to bring people's hips in line with their head and their feet. But for many clients, that's going to put them into extension.
Yes.
So if I've got somebody who's got one of these issues, they may do their plank a little funky, right? They're going to just keep that slight posterior tilt. They'll probably be more flexed at their hips, and it won't look as pretty. They won't be in a straight line, but that may give them the space they need to work the core while maintaining that openness and that decompression of the lumbar spine.
Something that I've learned with the plank, and I've seen this time and time again. I've been in hundreds of gyms. You see people doing it, and I will say this, how you cue the plank has everything to do with what's going to contract, how they're going to work their core, and how their body's going to respond to gravity in that position. And I say that's to say this. I've heard a lot of people say, I want you to tighten your abs, now tighten your butt, now tighten your quads, tighten everything, and really tighten everything and hold that. Okay. You're asking for greater compression. You're
Yeah.
asking for that body
Yeah.
to want to tighten up and
Hold together.
yeah,
Yeah.
hold everything tight. And what I joke about is I said, all you're going to lead to is a good case of hemorrhoids because you're tightening everything so tight. So, I try and talk them into, let's think about lengthening. I won't even cue their abs at the beginning. And
Yep.
I'll start them at a high plank. So they're on, the foot bar of a reformer or against the table, the Cadillac, or up against the wall. And I'll just talk about getting length, getting tall, holding that position. And if I then cue the abs, it's usually just pull them in half an inch. That's it. And usually if they're thinking about being tall, and pull their abs in half an inch, guess what happens to that spine? Naturally, it begins to straighten out slightly and go into a little bit of length, goes
Yep.
into a little bit of flexion even, but lengthening. And that is where I'll start them. So even if they could do a plank on the ground, I'll start them here first, because as I'm doing that, they're feeling the position and, oh, they're getting it into their body. Oh, some body awareness. And then you can begin to take them lower and lower to the ground. So when they get into a regular plank position, it's much more comfortable. They know how to lengthen. They can feel that elongation, and it's easier for you to cue.
Absolutely. And exactly. Those are this is where it's the refinement. It's not the exercise, it's how you teach it. And especially low
Absolutely.
back pain. I've watched a million instructors over the years teach stuff. And and you can see the instructor who's paying attention and is really cueing for that client in front of them. And then you can also see the teacher who's just saying the cues that they've heard a million times and they're not really paying attention to what's happening in front of them. When you're thinking about planks, you're thinking about one of the challenges with any client with these bony issues we're talking about is any kind of hip extension, right? So remember, we talked a little bit about this last time, but hip extension will often involve lumbar extension if you're not very careful. So, my other thing here is I will have a client, for example, leaning over the trap table or leaning over a box, and they will do their leg lifts or their hip extension just to the point where there's no change in their low back. They may be even over a physio ball or something where the back is staying relatively round, over a bolster, whatever, right? They're rounded. And then they're just going to lift that leg up. And I would do this monitoring their low back, because you can't always see what's happening under clothes and whatever. And then see how far can they lift that leg without that low back going into extension.
Yep. And
that's
my way of doing it, I love, is the physio ball.
Yeah.
For a lot of reasons. One, it feels good. It puts them in that natural rounded position. So they're automatically flexed at the spine. And then I can adjust them with their upper body. I can have them lower to the ground or more in a straightened position, that I can adjust that and have them and fine tune it myself. And then literally I can have them lift that leg 1 inch, 2 inches, 3 inches, and keep going until I see that spine wanting to arch. When you see the spine go into even the hint of extension, you just say, that's it. That's as far as you go. And one of my favorite exercises for this is just having an isometric contraction. I'll go into hip extension, hold that position, and just say, hold it for 10 seconds. Just hold it. And then tap down and then do the same leg again. Go into extension, hold it. But what my eyes are on, and as the trainer or as the instructor, your eyes should be on their spine, because that's really what you want to make sure they are not going into extension. And as they do that, you're going to see that they're going to get greater hip extension over time as their glutes become more involved, more engaged, because as we know, glutes have a tendency to shut off, when we have low back pain. So we're waking up the glutes, we're getting good gluteal activation. But by lifting that leg and just holding it, we're waking that area up. They're getting some strength, but more importantly, they're getting awareness. They're getting awareness of being able to do hip extension while keeping their spine in their safe neutral. which is the important part.
Because it's also about core support. I mean, it's also about understanding how do you support the low back. And so, if I think about that and I really am trying to keep my low back from extending, I've got to use abdominal support on the front side of that, right? So it's a way also to get the core working to stabilize the low back, to stabilize the pelvis, so I can get that area going. So these are ways to think about. Yeah. Go on.
I just wanted to add one more thing into this. And it's just a reminder for these clients who need to be in a posterior tilt, who have these issues. If you put them into a prone position, so they're lying on the ground. Remember last time we talked about generalized low back pain. Sometimes by putting them on their stomach, their back can sink into some extension. Well, guess what? In this situation, that's going to be contraindicated. So I have a pretty good sized pillow that I got from, Target or Walmart or something like that, a pretty good sized pillow that I'll put underneath their stomach, not their hips. Important. Under their stomach, because under their stomach will create that flexion in the spine. Under the hips, believe it or not, you're going to see them go into a little bit of extension.
Mm-hmm.
So you want it under the stomach, and I put my hands on their back and I actually sort of almost like I'm smoothing out their shirt. I'll just gently assist so that they can feel what it's like to lengthen, like I'm smoothing out their shirt, and they'll feel, oh, okay. And now they're in a safe position if they need to be on their stomach. If I'm doing something with their head or their shoulders, W's, T's, scapular work, whatever I need to do, I can keep them safe while still having them in the prone position. Or if I'm stretching them, putting the pillow underneath their stomach, if they're in a prone position, these work great. It's one of those things that I highly, highly recommend if your client needs to be in flexion.
One other tip. I know a lot of tips and pointers. This seems to be the scheme of the day. Because one of the other place that I find is problematic is sitting. Right. So if you're doing something in a sitting position, and I like to try to train all my clients, especially any low back client, with how they can sit most comfortably.
Mm-hmm.
Right. Because oftentimes they're sitting in their car, getting to you and getting back from you. They're sitting at work, they're sitting at home. And oftentimes that's a problematic position. If somebody finds, and the reason I'm saying that specifically for these folks is if they find that flexion is relieving for them, they may be really sinking in their flexion when they sit. They may be really just collapsing. Again, I work at Bounce Body, and I walk around the room, and we call it the vulture, the cube vulture, because people are so flexed in their spine, their shoulders are rounded forward, their hands are on the keyboard, and they look like a vulture. But I also really see that very unsupported lumbar flexion.
Yeah.
So here, like if I've got somebody who needs to flex for pain relief, I'm still going to say, okay, so yes, maintain that flexion, but think about like pushing into the floor, using your abdominals to keep that support, and keep that elongation, keep that decompression, even in that flexed position. And I'll train that in sitting, and for example, some of the seated arm work that we do in the Pilates environment, I might have them seated on the chair. How do they work that on the chair? So situations where they're in that seated position, but they're still finding that support, because that's where I often feel like they just give in, and that's not what we're looking for.
We want, you use the perfect word. We want support, not collapse.
Right.
How many times have you worked with a client and you ask them to sit down, and they don't sit down gracefully? They don't sit down with the grace of a ballet dancer. What do they do?
Slump.
Bang.
Right. They land hard and they slump.
And they slump immediately. Oh, yeah. And I'm thinking, oh my gosh, your spine did not like that landing, believe me. But it's something to keep in mind, especially if you're having them do something like a box squat where they're, sitting their tush down and then standing up. I'll do stand up and sit downs in a chair or off the edge of a high table or something to train squats. But you watch them and they collapse, boom, every single time. Well, if they're doing that in front of you during exercise, you think they're doing that at home?
Yes.
Of course. Of course. So awareness and really reminding them to support themselves when they're seated, to use their abdominals, to hold that flexion position. I mean, I'm just sitting here right now and I can feel my abs are slightly engaged. My back does like to be in slight flexion because I have a little bit of facet joint syndrome. So I find that by supporting myself and feeling that support in my abdominals really helps to lengthen that area. And I'm not just sort of collapsed, which is what everybody's tendency is to sort of just let all the muscles go and don't, nothing's contracting.
So this is, again, thinking about it in prone, thinking about it with our curls, thinking about it in our planks, thinking about it in seated. All little tips and tricks, because the one thing Brian and I say, and we say this a lot, so you'll hear this throughout the series, is if you can find a more comfortable position for them to work in, use it, right?
Yes.
And yes, over time, you can expand their repertoire of things that are comfortable. But the first step with all my low back clients is, how can we make you as comfortable as possible? Because until they're relatively comfortable, feel relatively safe, they just don't have the confidence to move. When the low back is really, really painful, most clients just they curl into a ball. I mean, not literally, but psychically. Like, everything hurts. I'm scared. I'm not courageous. I don't want to move too big. They just get scared, and you really have to work through the fear first to get them to get some little confidence. Oh yeah, that does feel better. I can feel better. There's a possibility for things to improve. And then you build on that confidence, right? Step by step.
Now, something that I want to add in here is, and this is in the fitness world as well as the Pilates world, are two words: neutral spine. I think we get hung up on trying to get everybody into that neutral spine position and depending on what book you read, depending on who you talk to, there's many definitions of what neutral spine is. For a client with a back injury, for someone who has some issues, their neutral spine is going to be the position where they can exercise comfortably, where they can maintain their posture without additional pain, or without pain, hopefully. So for someone who has a bony issue, their neutral spine will be flexed. And guess what? It may be that way forever. They don't necessarily need to go into traditional neutral spine. It's not a necessity for them to live if being slightly tilted under when they walk and when they stand and when they're moving. If they're out of pain, well, guess what? That may be the safest position for them, and it may be where they're the most comfortable. So I try and remind people it's not an imperative to get them into that traditional neutral spine.
That's so important, Brian. I just want to take a marker and underline that like 17 times, that with clients with low back pain or SI joint or other kinds of things, their position and their comfort in a position is their neutral. I have many clients that I think, Brian's worked with a lot more stenosis clients than I have, but I work with a couple where it's like, we just train them in that slight flexion. They walk in it, they sit in it, they stand in it. They're like, that's where they live. And when they do that, they can get through their day. They can be pretty comfortable with most of the things they need to do in life. If something stresses them out and they're not in that position for a period of time, their pain may return, but they can really work on that as just that lets me get through my life. And, there's not an ideal here. It's what works for that person in their life to make them as functional as possible. And, same thing with my disc clients. A lot of them stick their tailbone out a lot, and they're kind of in a little more anterior tilt or a little more lordosis than might be ideal from a neutral perspective. But that keeps them out of pain, that keeps them organized, that allows them to live their life. And that's the most important thing, is what does that client need to do, especially low back pain, what position works for them to keep them happy. So again, underline that, give an exclamation point. Don't get obsessed about what they should be able to do. Look at what they can do. Very important. Thank you.
Every time I think about this, I think of a client that I had a couple of years ago who had serious stenosis. I mean, serious stenosis. He had central stenosis as well as a little bit of lateral stenosis. Now, central stenosis is the type of stenosis that actually squeezes the central canal and squeezes on the actual spinal cord here. And for him, he really needed to be flexed beyond what you would think someone should be flexed in order to walk and do things. if he had to stand for more than about 2 or 3 minutes, he would find a wall and literally lean back against it, flatten his back against the wall, and lengthen his spine, get into that flexed posture, and maintain that for as long as he had to stand. So for him, literally teaching him how to walk in a posterior tilt while lengthening his spine was huge. That helped him out incredibly because he was able to actually function and get through, functions. He worked on Capitol Hill, so he had to do these things. And he was in unbelievable pain. So by teaching him where his neutral was, getting him aware of the position, and getting him to be able to move properly while maintaining that. So really teaching him his neutral spine made all the difference in the world in helping him with a greater quality of life.
And that's our job.
Yeah.
Like, it's not to make them something we think they should be. It's to give them a greater quality of life. I think that says it quite well.
And that is something that I think not every trainer, and I don't think not every Pilates instructor thinks about.
Yep.
Because we get hung up on the choreography or on what we've learned in the last, workshop or whatever we've learned. And we want the client to fit into the mold that we think they should fit in, rather than us modifying our exercise and our programming for their bodies and their lives, which is much more important.
Exactly. So here we've looked at or spoken to stenosis, degenerative disc disease, degenerative joint disease, arthritis, spondylolysis, spondylolisthesis, and all of those things, again, they're kind of in the same category in a lot of ways, right? So thinking about that slight flexion bias, and again, only if there's a reason, right? If they really need that for pain control, then really limit their movement. One thing I want to say is sometimes for some of my clients, they get very stuck in, this is the only way that I can ever move ever for the rest of my life. Like I think of one client who, and I have no idea what the truth is. She said she was seeing a practitioner of another method. And that practitioner said she had some sacroiliac joint issues, low back issues. And she said, well, you should just take very small steps. And this was like a while before she came to see me. So this client came in and she was literally not stepping more than about like 1 foot length at a time, like toe to toe kind of thing. And I was like, that's an interesting gait pattern. Like, what's happening there? And she said, oh, well, this instructor a while ago, I think it was more than a couple of years ago, told me I should just take small steps to minimize my pain. And that clued me in, and not only in her, but in many, many, many of my clients, to those things that worked at one point for decreasing pain become almost like a ritual, or this is the thing that I've got to hold on to that will make me feel better.
Yep.
Right? You recognize that? And so often,
yes.
So oftentimes I've got to also pay attention to my fear and go, okay, wait a minute. You're really getting a whole lot better. Let's take a step. Let's move you a little bit towards more neutral position. Let's take a little bigger hip extension, like whatever it is, right? Just make them thinking about what is the next step. How do you progress them? And when I get to that point where I'm starting to progress them, I take it very slowly. And what that means is I teach one new exercise at a time. I do not teach 3 or 4. I don't give them a whole new workout. One other thing I'll say sometimes is these can be very boring workouts for you as a trainer. You may be doing the same 12 exercises for 3 months with that person. That doesn't matter. That's not about you. So just get over that. But then when I start to progress, I'm going to say, okay, we're just going to do this one thing. I'm just going to add this one move. And then I want to see how that went that night, the next day. And then, okay, that's good. Then we're going to try that for a couple of weeks. Then we're going to take maybe one more step. So when you get to progressions, and a lot of times the progressions for these clients that are challenging are adding load or adding spinal positions, right? Or adding movement, just movements in bigger ranges, whether it's torso, whether it's hips, or whether it's upper body. And so there it's like, okay, let's just try a little something. Let's try a little tiny side bend where you're sitting at your desk and you have a hand on the side, you reach one arm up and you just tilt slightly over, right? It's just a tiny little something. And we see how that goes. And then we gradually build that up. And maybe eventually they do something like a side plank or something like a mermaid. But we start small and we really see how they respond. So that's the other thing is don't forget to progress them at some point. We're talking about the beginning, but every now and then they really can move past that. And how do we get them to walk up the chain instead of staying in that same space?
Yeah. But I love the fact that you said slowly, because I think a lot of times we think, oh, they've made a lot of progress, so let's do more, let's do more, let's do more, let's do more, without realizing that for them, just doing one new exercise can be a huge improvement and get them moving their bodies differently. Stick with that for a little bit.
Yeah.
Then one more thing, and stick with that for a little bit, because that can really affect the change over a long period of time rather than ramping it up too quickly, which can, set them back. I've seen that happen a number of times when I've been guilty of it. I get excited too. And the client's like, I can do so much. I'm like, yes, let's do this. Awesome. And then they're like, oh man, after that last workout, I kind of felt my back more than I had in a while. It's like, okay,
back
that's
up,
good information.
Take
a step back. What did we do different? Okay. Why did that bother it? Okay. Try and be the detective again and figure out what might have caused it. Because again, it's not always our responsibility. Sometimes it happened between, I saw them last Wednesday and I'm seeing them, the following Monday. Other things happen in that period of time. So I'm not always going to take all responsibility, but I will take responsibility for the exercises that we do. So we have to sort of look at that as well and just say, okay, we may have gone a little bit far on this. Let's back that down a little bit. Let's take a half a step back. I did want to mention one thing. When it comes to these clients, a lot of times you're going to find, and I'm talking about cardiovascular work. When working with cardiovascular clients who need to be in a flexed posture, okay, this can be difficult because what's the most common exercise that older people do is walking primarily. And a lot of times if they have stenosis or whatnot, the walking can actually cause them greater pain and they'll walk half a mile or a quarter mile or whatever it is. And they have to sit down. They have to take pressure off. So when they come to you, I highly recommend a stationary bike, but the recumbent one, because the recumbent is going to have their feet out in front of them. They're going to be in more of a flexed posture that can actually take pressure off and they'll fall in love with it. Trust me, as soon as they're on it, they're thinking, wow, I don't have any pain. I can actually work out here. But the other one is the elliptical. Now, there's only certain types that can do this, but if you have one that can adjust the cross ramp, and I'm thinking of Precor, that's the one that I prefer for this reason, because I work with a lot of spinal clients, people with back issues. If you can increase that cross ramp, you're decreasing the amount of hip extension with every repetition. So by increasing that, you're going to get greater hip flexion, but less hip extension. And so I may take them up a little bit higher than I would someone just in neutral. And then slowly over time, as they begin to go into a little bit of, greater range of motion, I can drop that down one notch at a time to see how their body feels. But it's a great way that I can get them in a standing position, which is a little bit more functional, obviously, but also reduce the amount of hip extension, which hopefully will reduce the amount of lumbar extension as well.
Nice. Good. Because that is one of the things, right? It's like if you can't walk or walking is problematic, and that's the easiest thing for people to do typically is to walk, and biking is not always comfortable. I mean, biking is a relatively flexed lumbar position, but not everybody can bike. So the recumbent bike,
saddle hurts some people.
Yeah, the saddle can be really uncomfortable. It took me 4 tries to get a saddle that didn't make my right leg go numb, for example. So that's pretty typical on that one. But I like that. That's great. So just take an elliptical where you can really adjust the hip extension piece on it. Awesome.
Yeah.
So I love it.
Just a couple of tips and tricks. One posture we didn't talk that much about yet, and I want to cover it before we finish up today and give a couple of ideas, is standing.
Yep.
How many times have you, Nora, seen this? And I see it more in females. And the reason is because I think when you get into heels, women have a tendency to lock their knees a little bit more. And as soon as they go into a lock knee position, their back goes into greater extension. And
Yep.
if you put high heels into the mix, I mean, that blows it out of, I mean, that's going to
Yes.
put them into extension anyway.
Yep.
I see this in men as well, especially who wear dress shoes, because that increases them by like an inch in the back. And they can also go into lock knee position and go into greater spinal extension. So just by cueing, soften your knees, it can
Hmm.
help that back to just soften a little bit. I'm not telling them to stand in a squat. No, just soften your knees, just unlock them. That can cause a huge amount of help for clients who have or need to stay away from, more of a lordotic position or more of a back extension position, and put them into a little bit of flexion to take some pressure off.
Nice. And using your advice, if I'm giving fashion advice to my low back clients, I might have them choose their foot gear based
Yeah.
on things that aren't going to bother them so much. And sometimes, some different people have different abilities to do that. If you're in a particular profession, I'm thinking about you in Washington, D.C. Here in Sacramento, like everybody wears athleisure wear all the time and sneakers. So, you can go to business meeting with pretty much anything on.
Anything.
Not true in D.C. Or many
No.
other places in the world. So in that case, it's like, okay, well, just try a lower heel. If you're used to a 2-inch, try a 1-inch. I know you may not feel as attractive. It may not do what you need it to do, but just decrease that. And then only wear those when you need them. Spend the rest of the time in trainers or in
Yep.
a heel that's lower, just so that you really are taking care of that and not irritating it just by your foot gear, which is not necessary all the time.
And something to remind your clients. I do this all the time. In life, in general, there's a consequence for all of our actions. And you can make the decision to wear 3-inch heels, but understand that you are accepting what the consequence may be for that if you're wearing them for a prolonged period of time. For a
Yep.
few minutes may not be a big deal, but if you're going to a wedding and
Yeah.
you're going to be dancing on them and you're going to be standing the whole time, let's say you go to a wedding and there's no seats and everybody's standing and you're in 3-inch heels, and then there's the reception and yada yada yada, you're hours standing. Well, guess what? There's going to be a consequence for that, and it's possibly going to hurt. So you may want to make some different decisions, or just understand that, you're probably going to have some discomfort for a period of time afterward, and just be okay with that.
And if you've got things that don't make you feel better, make a plan. Like I say this a lot for
Oh,
people. It's
yeah.
like, okay, so you've got a wedding or you've got a big special speaking engagement or whatever it is, and you're going to be stressed and whatever. Make a plan. So after that, I'm going to go back to my hotel room or go back where I'm going, and I'm going to do this and this and this thing that I know will help me out.
Yep.
Maybe if it's icing helps them, if heat helps them, if stretching helps them, like what are the things that usually ease some of that up, and then just do that, commit to that. And that
Yep.
often is a really nice way to train clients to take care of themselves, which I find for any low back patient, that is also the thing, is they've
Yes.
got to learn to manage this, because that's really the thing that's going to make the biggest difference for them. You'll see them once a week, twice a week, 3 times a week. The rest of the time, they're on their own. And the more you can help them to figure out how to make those improvements and feel better on their own, the better.
Yep. Absolutely. I mean, we've been at this an hour, and I feel like this has been a really big tips and trick heavy episode on spinal flexion, which I think it needed to be. I think we
Yeah.
really want to be able to give you an idea of what you can do with your clients that is on a practical application, because it's one thing to be told why to put them in spinal flexion, and we did. We're opening up those facet joints, and it's important to do that, and that intervertebral space. But you want to make sure you have the skills and the tips, the tricks, whatever you need in order to put them in those postures, and how to keep them there and create that awareness. So I think that we covered a lot of that today. And I think we went over a lot in all the different body positions that you'd have your clients during exercise.
Yep, exactly. So we're going to do discs next time, I think.
Yep.
Yeah, looking at discs and stuff, which again, we've talked a bit about sciatica already. We'll talk a little bit about disc things next time. And then we're going to, the last one is, I think, as we've talked about anyway, if it will be the last one, is to really look at specific exercise techniques and progressions and that kind of thing. So we'll
Yep.
spend a little more time on that. And there'll be a lot of that in all these things. And like we try to give you some things you can take home and things you can do tomorrow.
Yeah, that final one's going to be a lot of strategy. It's going to be how do you progress them? Where should you start with each one, et cetera, so that you actually have the strategies to progress them. Because all too often we're not thinking about progression as much as we're thinking about today's session. So you really want to
Yeah,
think about, okay, we want to progress them over the next few months to the point where they may not have to think about this again, or until they hurt, injure their back 5 years from now or whatever, if it happens in the future. You really want to think about progressing them to that point where they can do more general fitness type of things or general Pilates or be able to take a mat class or whatever's appropriate for the client.
exactly.
All right.
There's our
Well,
hour. Our hour is up. Moving conversations complete.
we did it again. We covered an hour very easily. Like we say every week, do us a favor, hit the like and subscribe button on the platform of your choice. You can always reach us at Moving Combos on Instagram, as well as movingcombos@gmail.com. Those are the best ways to get in touch with us. Check out the YouTube channel. My name, Brian Ritchie. And for Nora St. John, I'm Brian Ritchie. We'll see you next week.
Bye, guys.